Hi, this is Dr. David Nace, Chief Medical Officer here at Innovaccer, and I want to welcome you to our webinar today, Mastering New Payment Models in the Age of Value-Based Care. Something really important to all of us who want to understand this movement away from fee-for-service and this drive toward taking risk as healthcare providers. So with that, let's get started. First of all, I would like to give some housekeeping rules. We'll be taking questions at the end as well as during some of our polls. So please be sure to use your toolbar to enter your questions into the XXX box throughout the webinar, and I'll be able to see those, and we'll use those questions to ask questions of our panelists at the end of the session as well as potentially during some of the polls. And with that, let me introduce our speakers. And we have quite a great crew here. Let's start with Phil Fasano. Phil is the former CIO at Kaiser Permanente and AIG, just a stellar reputation as a National Chief Information Officer and also a strategic advisor to us here at Innovaccer. Phil, welcome to the webinar.
I'm glad to be here, David. Thank you.
Great to have you. And we also have Melanie Matthews. She is the Chief Executive Officer of Physicians of Southwest Washington. Melanie, great to have you on board. And I hear that you're in Washington, D.C. today, not the state of Washington.
I am. I'm delighted to be here. And I'm in D.C. working on some legislative priorities related to ACO, and happy to share some of my thoughts around what's going on here as we proceed through this webinar. So thank you for the invitation to participate.
Absolutely. Thanks for coming. And we also have your colleague, Tamra, Ruymann, who is the Chief of Digital Health. I love that title, by the way, of the Physicians of Southwest Washington. So Tamra, welcome, and I mean, you might want to say a comment. That's an awesome title.
Well, thank you very much, Dr. Nace. I appreciate you having me.
Yep, and it's great to have this move into digital health, and that's what we're here to talk about. So with that, let's get into it. So this is the driver that we all know, and it's always nice to keep in mind that the costs of healthcare keep rising far faster than the inflation rate. And they continue to eat up more and more of our gross national product. And the value we get from that is not great. Phil, you know, you've talked a lot in the past about this movement from fee-for-service into a different model, and you've got great experience from Kaiser. You know, in the fee-for-service model, people can make money a certain way, and they may not want to move away from that. So say a little bit about your thoughts about the movement from fee-for-service into value-based care. How do we do that?
Well, David, a couple of thoughts. One, first, the chart you just put up is frightening in itself, to see the costs ultimately rising almost 20% of GDP. And the real challenge there, I remember when I used to be on stage as a CIO at Kaiser, we were talking about $2.5 trillion. Now we're talking, what, 3.5 and going above that at a pretty rapid pace. You know, bending the cost curve has been something that we've been talking about in this industry for a long, long time. Unfortunately, we've kind of failed at it, and there's a lot of drivers why we failed at it. And it isn't all about fee-for-service, but fee-for-service is one of the contributing factors in combination with, you know, paying essentially for, you know, piece parts as opposed to focusing on quality, and then ultimately cost follows. Quality improvements in health and health improvements overall tend to bend the cost curve. And we saw that inside of Kaiser during my tenure, and I know they continue to see it today. And everyone will say to me that, you know, you were Kaiser. Partly true. I believe a lot of the lessons that we learned at Kaiser and how to do this, particularly with today's technology, can be achieved regardless of whether you're Kaiser or not. And I think that excuse is long gone in terms of the entire industry not being able to, you know, achieve the same outcomes and the same performance levels that Kaiser does. I think the technology out there today, including some of the things you guys do, enables that in a way that's quite material.
Yeah, I appreciate that. And, you know, I think this last bullet on this slide is in most of this country, people have some mix of fee-for-service as they move into these ACO contracts, risk-based contracts, et cetera. Very different journey than Kaiser had. And sometimes these fee-for-service are appropriate, and so you want to mix. Let's talk a little bit about that and ask our other panelists their thoughts on this. So, Melanie, say a little bit about your experience in working with physicians as they move away from fee-for-service into fee-for-value. Talk about fee-for-value. What does that mean? What are the different ways to think about paying where you can actually improve value?
Well, I think one of the key drivers is to align the physician's incentives around being able to be successful in the value-based payment. I think when we look at engaging providers and we look at moving systems of care, and I sort of echo the comments that Phil made around the excuses aren't there anymore, and that there's data and ability to utilize information to drive decision to prioritize efforts in terms of how we engage both patients and providers. I think throughout the continuum, I think that could be said for other stakeholders like family members as well. But what I see around the engaging strategy for physicians at moving along the continuum from volume to value is to understand that our chassis for the eat what you kill model in healthcare hasn't provided, particularly as we need in primary care. We need more access. We need more focus on the preventative measures to keep folks out of the higher acuity settings that are not necessarily appropriate, but get utilized by virtue of not having the physicians designed and aligned to have their financial model allow them to be successful. So if you have to see 25 patients a day, I'm just making up the numbers, in order to break even at managing your practice and being able to pay yourself a salary, then if you're taking care of 20 patients well, instead of 25 patients not as well as you could, currently the financial alignments in many scenarios are not consistent with paying the providers that are taking care of 20 patients really well better. And that's what we've done to really have the catalyst for change on provider alignment, is to provide actionable data of where do you find the needle in the haystack in terms of what we should be doing for the right patients in the right care system, engaging those providers, but also being able to compensate the reimbursement structure and change sort of the shape of revenue. So the better that we perform, the better the physicians can be compensated. Therefore, it's a feedback loop. We can put more resources next to the bedside to help the providers. So there's a story of how we can move there. And I think that we're in the middle of developing that story, and we're kind of throwing a lot of spaghetti on the wall and figuring out what sticks to align both the patients and the providers in this new model of care.
Those are great insights, and I particularly like what you said about the use of data, and that now we have basically, it sounds like we have a spotlight. We can see what's going on. We can see how people are performing. Tamra, you're the chief of data health. Say a little bit more about your view of how data has really helped us move into these new models of care, alternative models.
Yeah, as Melanie had indicated, we're throwing a lot of spaghetti on the wall, and what that means is that we're consistently modeling with the data to determine what areas we can share with the providers that would allow them to understand what they're doing. And it would also tie to potentially providing incentives that move them forward. It also is important to note that many of the different payers in the area are moving towards this. It's not just the Medicare ACOs as we're seeing from the get-go. And so having the ability to share with those payers the data that supports what your outcomes are is especially helpful when you're trying to move forward with other value-based contracts in this arena.
So Melanie, you're in Washington and you're hearing what we already know. I mean, we already know that CMS decided back in December to say, ultimately, over the next 5 years, we're going to move everybody into taking risk. So what does that mean for people? Like, do you think people are ready for that? What do you think the implications of what you're hearing in Washington is? We really move people onto that highway of taking on risk.
Right. Well, it's probably the third, and the third theory, right? A third are going to be early adopters, sort of the tip of the spear. How do we figure out how to operate in a new model? I think you're going to have a third of like, I'm not going to do it. until I have to. And then you have a third that says, I don't think it's going to happen. I'm not going to make any investments or manage an infrastructure. I think that when we look at, I would see the tea leaves, both from a federal perspective as well as states, is that it's not a sustainable trajectory for GDP. I mean, Phil started us off, you started us off talking about the national landscape and the drivers around what we're spending in healthcare. And frankly, we're not seeing the results in terms of quality. So we're seeing increase in costs and we're not seeing an improvement in quality under the fee-for-service chassis. I'm not thinking that the whole, like I agree that there's still going to be a time and place for fee-for-service, but I think the general construct is that we need as an industry, when we say we've failed, and we have, is that we need to think about, let's take the lessons learned by some of these programs that are showing success at improving the quality and reducing the costs. And frankly, that, you know, that when it went from a triple aim to a quadruple aim, adding provider satisfaction, is that providers are not happy with the healthcare delivery system. And I think that being able, they want to do the right thing. And I think that they got into medicine to do the right thing and take care of their patients. And so I think as we can build the story and show and demonstrate the outcomes and the engagement and the quality, then we can also tell the compelling story to the provider that by moving to value-based care, we're making investments into a more holistic approach to medicine. And that provides resources and tools that are not currently provided under the fee-for-service chassis. So if you're only paid by each code you drop, you know, having medically related social workers or care navigators, or, you know, I perceive that our organization, basically by taking risk, we invest in, I call them, you know, shepherds through the healthcare system, and they shepherd the patients through navigating the complexity, both within understanding what your benefits are, as well as coordinating the care across the continuum, which is otherwise fairly fragmented. I think as Tamra talks about the data pieces, and as a digital health, you know, really focusing on that, is that things are really complex and we need to be able to leverage some tools to help us figure out how to navigate where to direct our efforts and to provide support, again, to the patients and to the providers both. I look at it as an approach that we need to be, you know, concurrent with, that we have to keep the provider in mind as well as patient engagement strategy. I think CMS, I'm just going to make one more comment. I think CMS and CMMI has bipartisan support to continue down the path of moving and escalating that risk. We saw new bundles that were released. We're waiting for the Office of Actuary to certify the next gen has met its deliverables in its final years, 2020. And then we've had a lot of engagement, and I've been very involved in the new direct contracting models that are being launched. And if you see what's going on, is the government, both at a federal and state level, is shifting risk from the government itself to larger organizations. I think we have a lot to learn from Kaiser and those before us that have sort of paved the way to showing that we can do a higher quality, higher satisfaction, lower cost delivery system. And so I'm an early adopter and want to embrace those principles.
No, that makes a lot of sense. And let's take a look and take a break from our audience, kind of what phase they are in the implementation of this concept of move to or population health management. And it sounds like, I think your point, we need data and we need tools. So, and we have a quick question for Paul for the audience. You have 4 choices. Every practice across the network in your network has a robust population health management platform. We understand as an organization, you population health, and you've started to do some things. We're just starting to understand population health management, and the data and tools required, you've not even started. So let's give our audience a few minutes. But I want to turn to Tamra. I like this digital health. You know, we started with the stimulus plan, getting everybody to adopt electronic health records. And so did that really get us into this concept of digital health, or what do you think is now evolving from this in terms of moving beyond just the EHR?
No, I don't believe that it got us where we wanted to be. I believe that the new FHIR movement is actually going to help us through the Blue Button 2.0 that CMS is putting through, allow us to actually grab data and use that data in a way that we haven't seen the ability to do in the past.
Now that makes sense, and I know we've worked with you here at Innovaccer in putting a platform for data activation behind you. How have you seen the important elements of working across the network and bringing people together with things like Blue Button, interoperability? What's been a secret sauce? Because just a preview for what we're going to get into.
Well, I think it's kind of in the early stages right now for connectivity. We are we're not a single system, and so we have multiple disparate EHRs, and we are seeing for the first time the ability to bring that data together utilizing your system. It's allowing us to really do some risk stratification for our care management team, and I think that it will continue to grow. Again, just our primary care, we have 23 disparate EHRs, and so you guys have helped us put that together so that we're able to start seeing all that clinical data in one space.
No, that makes a lot of sense. You know, we got everybody to adopt EHRs, but they don't all talk to do that.
Hey, David, if I might add a point, even years ago, this was an insurmountable mountain for most people in healthcare, unless you had an abundance of money and a very large technology organization like Kaiser did, which is why people always said to me, "You guys are Kaiser," and of course that's the reason you can do this. We actually connected all our systems there, but I spent enormous amounts of money, billions of dollars, doing that. Today you can do it without even coming close to that kind of spend. And really do it even better than we did. So I think this is it's a huge motivator for me as I look at what the industry is able to do now.
That makes sense. So let's take a look at what our audience thinks. We have the poll results in, and drum roll please while we bring up the results. Let's see. Interesting. 51%, the highest amount, understand population health and have started to implement some aspects. Still a large percentage just starting, and some folks aren't even thinking about it. Melanie, what do you think about what we see here, this diversity of response?
Well, I'm not surprised by this. I think that, you know, when I would look at how I would respond, I would say I understand and I've implemented aspects. I certainly spent a lot of time in this space. Our organization is uniquely positioned to have this to be our primary focus, but as an IPA and as an ACO, but many of the organizations that presumably are on the call are part of systems of care that are grounded in a model, and then they're trying to, you know, build the infrastructure to be, you know, be proficient at moving into value-based care. And so one of the things I think about population health companies, and that's what I vision ourselves as, is that, you know, we're a bit of a kayak in that we can paddle fast and around the corners because we're dedicated uniquely to that service line. If I was an integrated system of health or a large acute care hospital or, you know, that kind of delivery system, I think that it would be harder to make those investments and see the, you know, the progress along those lines. I think that, you know, lots of folks are having some aspects of it, but I think that this is the new frontier, and we're, again, back to the spaghetti on the wall, we're looking at what sticks. And I think one of those things as it relates to kind of some of the technology that Phil was speaking of, where we could align, he said it was insurmountable. I used to call the data infrastructure expense, you know, the widowmaker. It would be the death of us because we couldn't afford, at the time of the last 5 years, we couldn't really afford to make data aggregation speak to each other. Electronic health records are capturing date and time, point of care, dropping billing codes, connected to the revenue cycle, et cetera, but they weren't designed to aggregate data. If you're using EHR to do population health and the patient never walks in your door, you don't even have a record for them. So one of the key pieces, I think, is what implementation aspects are being, when we talk about seeing the green line here, which aspects are they implemented? So I don't know if you're going to ask those questions later, but I think it's interesting to see which investments have been made.
Yeah, and we'll take a look at what you've done there at PSW to talk about that. So let's just move on and take a look at this next slide. I love this cartoon. It's hilarious. So I think this is the choice people make, and you know, it's a struggle. You know, there was a famous quote from General Electric: "Culture eats strategy every day." So lots of people want to move into population health, adopt these technologies, but it's really hard to change. Phil, what's the secret sauce in kind of moving into risk? What are the key things people need to think about?
I think that's a great question, David. As I think about it, given where I've been and just really as an observer now of the industry, being able to connect all your data all the time about all the patients, which is really used to be really hard, and I think tools like yours are now making that world possible from being impossible years ago. And then the ability to really look at it through multiple lenses where you're able to measure quality and overall performance in delivering great care. And
no, that makes a lot of sense. Really being able to connect dots and get information and get it across your network, get it across your providers. That's great. So, we think about a portfolio that one might have of people move from risk from fee-for-service, but they have some business, some contracts with an insurance company that's a PPO, some doing shared savings, they move into an ACO, others may be doing bundle payment for like payment just for doing hip surgeries or knee surgeries within their population. Then there's all these models for shared risk, shared savings, et cetera, and then full risk like you did at Kaiser. I mean, it's really interesting to think about that. But the key is more risk, more revenue. Our good friend and colleague, David Nash from the College of Population Health at Jefferson, he often says, no outcome, no payment, right? So the point is you got to get the outcome, right? No outcome, no payment. So Melanie, you've taken a look at kind of moving into risk in a very significant way, and you're down in Washington talking about this. What are the new rules that you see coming forward, and how are people going to be able to succeed with them?
Well, I think in the legacy programs and sort of the programs that initially came out of the office from CMMI to test new models, that we saw the need to have upside models to engage groups to get involved without having significant financial risk. And I think that organizations, in order to see any difference in outcomes, needed to invest in infrastructure payment. And I think that CMMI has learned a great deal by working very closely with the stakeholders that have engaged in the early models and really taken feedback around prospective attribution. Really, you need to know who your patients are. You need to have a predictable model where you're able to understand your benchmarks. But I think what the hot off the press sort of communication in the last maybe 18 months from CMMI is that we're beginning to see that these models are saving the Medicare trust fund, which by the way is slated to run out by 2027. And so there's a sense of urgency to bend the cost curve, and there needs to be the catalyst for change. So I think that people were very comfortable in the upside only models, and that they weren't seeing the transition to double downside risk to up and downside risk at quite the volume and the trajectory that they had wanted to see. So the Pathways to Success and other regulations that have come out, including at the state level, have been recognizing that there needs to be a catalyst for change. And so we're going to make, instead of just the carrot approach, we're going to make a carrot and a stick approach. And so when the macro legislation came in and said, hey, if you don't, it's a zero-sum game, so basically we need losers to fund winners, it's a net neutral payment, it really was telling you that you're never really going to see any more money in the fee-for-service chassis. So Medicare made sort of a strong stance around that, and then created an array of models to help you qualify to be an advanced alternative payment model and have different eligibility for bonuses and so forth. But what CMS has done is really say that we're going to force you into that movement. The plus or minus 4% to 7% starts to become real money for practices if they aren't able to succeed in the fee-for-service quality, like you said. If you don't have the quality, no outcomes, no payment. So I think we're really seeing that there's more models coming out, and that they're really shifting the risk, and that this is not going away. And I can't impress upon you enough that the concept that there's bipartisan support for this effort means that this is not a particular White House or Senate or Congress initiative. I think this is, people are pretty bound together that need to improve the healthcare delivery system, and that this is an effective way of doing so.
No, that makes a lot of sense. You know, I like what you said about it's not just CMS Medicare now that we're moving into these new contracts, but you have to look at what's going on at the state level as well. We here at Innovaccer have done a recent analysis at the state level by adjusting for the risk of the population to see which states are really moving into risk at what rate. And as you see here as a heat map, right, you see California, Texas to a large extent, some interesting states like Mississippi, really starting to take on risk. New Jersey, we would expect, New York City in particular, and then other states that are being a little slower. And we see state of Washington, where you're at, is sort of in the middle, right? Moving along, starting to take risk, almost becoming very dark here. So we're actually going to supply this recent publication, the State of the Union report, with the healthcare at each state level. So this is a tremendous resource we're going to give to the attendees of the webinar. So please look forward to receiving that quickly. Let's now turn to looking at physicians of Southwest Washington, where both you and Tamra reside and kind of make everything, all this magic happen. Tamra, tell us a little bit about the overall the organization. Tell us the scope and size and kind of who you are, who your network is. Give us a general sense of the PSW arena.
So Physicians of Southwest Washington is an independent physician association. We're owned by independents in the local area, and we also have an owner of a large healthcare system a county away from us. And 3 years ago, we were primarily in the business of full risk contracts for Medicare Advantage. And since that time, we have diversified our portfolio. We are now have been in a next generation ACO since 2017. We also provide services for MSSP Track 1 Plus model, and we are currently working bundled payment care initiative for those people who aren't ready to just step straight into the next generation model. We do business for about all done and said, about 50,000 plus members currently, and that is expanding by 2020. And we work with a multitude of healthcare providers, about 550 plus. And, you know, we did really well in the Medicare Advantage arena, but we decided that we needed to move as the healthcare fee-for-service numbers kept closing the gap, and the need for services or the cost of services was increasing. Melanie, do you have anything else you want to say regarding that?
No, I was just going to say a couple of quick things. Thank you, Tamra, for the background. One is that we were brought together to form an IPA to aggregate the independent community physicians in our market to ensure that there was a voice to preserve the physician-patient relationship amongst a lot of contract negotiations and control that was being shown and displayed by payers. And so it was really a strategy of making sure that they could aggregate and align physicians so that they could focus on the patient relationship, and we could do some of the shared contracting for them. I also would say, just a comment about the growth, is that we need to matter to the providers in a way that isn't just a small subset of the population that they serve. We need to create muscle memory into the ability to take care of broader communities, so that we can put in care navigators and technology platforms and social determinants of health programs and remote patient monitoring and sort of all those kinds of services that we can provide. We can provide them because we take risk. And because by taking risk, we can make the infrastructure in place to fund some of those other services that help us reduce the overall medical loss ratio. So basically putting in some infrastructure to save the total healthcare spend. And so in order to do that, we needed to matter beyond the Medicare Advantage patients. And because we had that experience in risk, we felt confident that we could take on and share more risk. I just want to make a note. We have about 9,000 Medicare beneficiaries in that county, but we have about 17,000 in our ACO because we had expanded. So I just wanted to share that comment.
No, that's helpful. And I love your description of this journey from getting experience in Medicare Advantage, getting comfortable with managing risk, doing things that normally physicians wouldn't do, remote monitoring, social determinant of health data, trying to incorporate that into the work with the risk. and then moving into these other risk-based contracts as you get comfortable with it. That's that sort of on-ramp to the highway I think CMS is trying to push with the 5-year plan of moving everybody into risk down the road. So this is great. Now let's get into the secret sauce. Melanie, you oversee this organization. If you could say at a high level, and then we'll get to Tamra, what are the key levers, I think, that you need to pull for you at PSW as well as the providers in terms of actually managing this risk successfully as you have?
Well, first you have to repeat the message over and over and over again around why you're trying to do this, building the will. Why does this make sense? I think that being able to demonstrate success stories, like one of the ones that I always bring up is that we had a patient that was going to the ER every single week. So we did a home visit and evaluated that the patient really had social isolation. We came up with a care plan that involved calling the patient every day at the same time, and the ER visits stopped. Now, under a regular fee-for-service model, we know it's not good that they're going back to the ER, but it's not investing in the infrastructure to bring someone to their home, to evaluate the environment that was going on, to assess their resources. And so we were able to put interventions into place, and then we were successful at reducing the ER spend. So those are the kinds of success stories that I think our providers began to see. And when we aligned, because we did align financial incentives, we were able to get more attention to referring to us patients that they were concerned about. We also were able to leverage more data and analytics to figure out who was rising risk. It's one thing to deal with the tip of the pyramid, those that are already really sick, and there may be very little that can be done with them. But new chronic disease diagnosis and making sure that we identify those to put a care and plan and wraparound services is really paramount, I think, to the success. Really ensuring that we have access to primary care, that making sure the network is open, that there's no barriers. If you have to push the phone button 14 times to get someone to answer your call, you're probably going to go to the ER. And then I really did a lot of communication to our network in terms of what costs were for hospital admissions and ER and urgent care, so that physicians could really understand what the price point was across the delivery system. And it's really atrocious that our medical community doesn't even really know what healthcare costs are. So I think we provided a lot of education in our market around visibility into what those cost structures look like. And then really care navigators to, like I said, shepherd patients through the delivery system. So those are kind of some of our main drivers. And then data, concise data that's actionable, that they can relate to. So those are big, and those are big drivers for our success. And then lastly was, beneficiary engagement. I think it's very clear in the 2 slides, which I'm not going to read to you, but they tell us, like, what do we need the providers to do? They like to be told, like, this is what you need me to do. And then I say, this is what we're going to do for you. So just sort of a simple construct on setting expectations, not with all the complexity of innovation models, but just what do you need to do? You need to refer patients that are at risk of going to the hospital to us. You need to let us do direct admissions to skilled nursing, utilize waivers that aren't typically provided in the traditional fee-for-service. One of the benefits of innovation models and taking risk is you can have different waivers that allow you to do things that aren't allowed under the traditional programs. And then, really because of EHRs being, Tamra shared, we have 23 different primary care EHR instances, is that we needed a way of aggregating that data so that we could figure out how to prioritize our efforts. So
that makes a lot of sense. And I love the story you gave about the patient with social isolation and how you detected it as looking at the ED utilization, reached out for this particular story, found out by visiting the home they had social isolation, and then came up with a plan to address that. By doing this with a lot of people in the population, you were able to really reduce the ED utilization. Tamra, I'm sure you have some stories of where particularly data can help really accomplish many of these levers that you're pulling here that we see here to really get value and reduce your costs and improve quality of care. Tamra, what stories have you seen in terms of working with patients or with the physicians?
Well, I would like to just talk a little bit about our ED utilization and what we've done in order to reduce that cost. So we've seen over the last couple of years a significant reduction in our ED costs, and what we have been able to accomplish utilizing the Innovaccer system, but putting into place some workflows here that allowed us to do that, and then we took the technology and really were able to do some more automation of that. The education of the patients, the beneficiaries, is important. We had a lot of urgent care here in our area, but it wasn't being used as it could have been. And so using the admit, discharge, transfer feeds from our local area hospitals, we were able to identify almost immediately through the system patients that had visited the ER and were discharged, so that our care managers could actually do some outreach to them. And we were able to reduce like avoidable ED visits by engaging and educating those patients on the urgent care. We created some collaterals. We engaged our providers with the collateral materials so that they're showcasing those within their waiting rooms. And this has allowed us, and I know that we haven't changed our slides, but this has allowed us to do some reduction effectively up to almost 20%, I think, in 2018, and we're still seeing that reduction for 2019 and hoping that it will increase even more for the 2019 year.
And here's an interesting story just to piggyback on what Tamra is saying on the ER, is that when we were talking to our board about the need to reduce ER, it was really interesting. And we're physician governed, independent primary care and specialty, half and half. And what was really interesting when Tamra started to show the data about the ER was well, they're going to ER when our offices are closed. And Tamra was able to show date and time and analyze that actually the primary ER was happening during business hours, and only 25% of patients were being admitted, meaning presumably some of that 75% going to the ER could have been handled in a less restrictive or a less costly setting, more appropriate setting. So I think that one of the things that Tamra has been able to do is provide data to drive behavior and change and open eyes into maybe what an assumption is, but when you see the data, you're able to really maybe stitch together the story in a different way.
No, that makes sense. So I love this next slide, and these stories really come together where you've taken a very broad-based view of all the different ways that you can sort of improve value within your population and really creating a population health management platform, which I know we've been helping you from the technology side to do. Can you give us, Tamra, just an overview from a digital health perspective? How does an organization pull all this together? Like, how do you decide what to focus on, what not to? There's lots of data coming in. It's all being activated, say, from our platform. How do you make your decisions, and how do you allocate your resources?
Well, I think what Melanie has done a good job of promoting for our company is that you need to keep it simple. So we've seen a lot of systems who try to plunge into value-based care, and they end up over engineering what they're doing and trying to work on too many things at one time. And so what we've done is we've really focused on some major initiatives here, but limited them so that we could get good at them. And again, it goes back to the spaghetti on the wall. So you focus for time on a few measures, and you see how that assists you in reducing the cost of care. And from there, you identify if there's additional that you want to move forward with, or if you are good with are the ones that you're currently working on. And we keep refining our processes. But as you will see, we've outlined what our population health management platform in this slide looks like. And we have used some very simple pieces. As I indicated before, the ADT feed is really doing a lot of feeding for our chronic disease management. It allows us to set up the case managers with the people that they need to do outreach to through discharges. It allows us to identify potential remote patient monitoring candidates. It also allows us to work to engage those patients who are high risk into a care management ongoing protocol. And in the meantime, all of the data that's brought together on the the data platform is feeding the case manager in their work so that they're able to understand what some of the quality measures are that might be outstanding, what their current RAF score is, and what might be outstanding. And in addition, there's this information is available to the provider at the point of care, so they're able to see it when they're face-to-face with the patient and have the ability to utilize that information to get some of those quality gaps closed and make sure that they are in the know about everything that's happening with that patient. And they also are able to understand, because again, we're an IPA, so we don't do our care management from within the clinic. So our providers are able to know what kind of case management, what's been happening with their patient through our systems.
That makes sense. And Phil, this sort of looks like maybe it has some resemblance to Kaiser when you were there.
It's funny how you say that. I was just thinking that myself. We did all the plumbing was done by us at that time, and it's so great to hear organizations like this one talking about how they're able to get such great value from this, and how easy, I won't say easy, but the work is now a change management activity where you're actually working with people on this rather than all the grunt work of the systems. It's really a different conversation, and for me is extremely heartening. I'm loving hearing this.
Yeah, and I think, with great pride, we heard a little bit about the ED utilization that they've been able to reduce in a story that Melanie shared. But look at these results. I mean, using a data-driven strategy, 18.5 reduction in 2017. Anyway, great results, great applause, from all of us. And I think that just shows this kind of focus, this kind of broad-based approach, and the use of data to create such a platform and working closely with your providers and your patients.
And David, your comment about Kaiser, I just interrupt you for 1 second. These are the types of results we were seeing back then by connecting all of this. And we'd talk about them a lot, and people would just go, it's not possible. It's just not possible. And it's so nice to see it, because it's absolutely possible for everyone to do this.
Right.
Well, Phil, this is Melanie. I mean, I think you paved the way, right? So, one is, thank you to Kaiser and folks like yourself with your type of leadership that helped, create, like you said, the plumbing and hardwiring to be successful. One of the things I feel strongly about is that you just brought up the culture kind of change management principles that go along. But in terms of best practices and levers, you don't need to reinvent the wheel. There's very, proven interventions to be successful in this work. So it's not like you have to learn things from scratch. There's been a lot of investment and learnings and success in other models like you brought forth. I think that you're spot on when you talk about it's a lot of change management.
Well, let's take a look at kind of how the audience is looking at what they're doing in terms of taking this sort of data platform approach, trying to leverage the sort of, what are the right ingredients for technology to really augment a team to take on this sort of approach. So quick 4 questions for the audience. What are you doing today? What do you think are the most important things in achieving these results for your network, for your organization? Is it keeping interoperability, giving insights to the physicians at the point of care, using analytics to identify and then address high-risk patients, or using analytics to look at just for reporting, for current, and so retrospective, so you can see where you've been, where you're going. So the poll is live. Please cast your vote now, and we'll track it as it comes in. And quick question, I think, for the audience, as I see these questions coming in from the audience. Melanie, let's start with you. Do you think compensation for non-providers in healthcare system is an important ingredient here? Other care workers besides providers?
Are you talking about aligning the compensation for which type of providers?
Yeah, well, let's talk about that, because the question is compensation for non-providers in the healthcare system included in this risk? And I think that would mean people that do community work or people that engage visiting homes. Do you use just clinicians or do you use non-providers?
Well, it was interesting that you say that, because when we set up the ACO, we involved our home health and skilled nursing post-acute care in the risk pool. And so one of the things is that I feel like some of the programs that have been put into place have targeted either specialties like bundles or in systems that have taken on models that have only been inclusive of their system, that it doesn't kind of bring the community. We're sort of really grassroots community led. We're small and nimble enough to do that. But I feel like it's imperative to involve the continuum of services. So that's the ambulatory surgery centers, the freestanding EDs and ERs, urgent care, post-acute care, and the array of services that are involved in that work. So to me, I feel like there should be an opportunity to participate in the model so that the whole community is, rowing in the same direction related to taking care of the populations. It's a covered life strategy, I would say, to have the risk throughout.
No, that makes a lot of sense. And let's just see if we can check in to see if our results, they're still streaming in. So here we go. I think we'll be able to see while we're waiting. Here we go. Oh, equally distributed. Interesting. So a strong focus on high-risk patient identification and also empowering providers with insights to the point of care. Let's talk about those two. Tamra, where do you see this role of identifying high-risk patients using data versus giving insights to the physician at the point of care? How do you see that playing out in your environment? How do you think of these results?
The results are very interesting. I think that actually all of these pieces are as important as the other, and identifying high-risk patients is great, but what are you going to do with them after you identify them? And being able to identify those patients and then provide the insights at the point of care to the provider so that they're aware of what the high-risk issues are with the patient is really like a combination that is a necessity.
That makes a lot of sense. And I think to your point, they're all equally important, and we see that, I think, in the audience as well. Let's move back to the presentation and dialogue, and we'll sort of get to the next area. This concept of data and technology seems to be so important. We tried this wave with the EMR, creating systems of record. Phil, you often talk about the second and third wave, and I know in your work with us here at Innovaccer, you talk about moving into the third wave. Tell us a little bit about how you see these waves of technology playing out and how it's going to help us in health. Speak for Focus, we do work together closely. I think the key is to connecting different systems. I think is, we were hearing from the folks at PSW, 32 or so different EHRs across the work. How do you connect them? And then how do you get real-time information exchange? Because we saw that important results in the poll that you want to give good information at the point of care to the physician so they're empowered when they're seeing patients. And then this movement in toward things like artificial intelligence, and we want to learn about that. So when Phil comes back, we'll ask him a few questions about that. So Tamra, we work with you here at Innovaccer. We talk about having a data activation panel. What does data activation mean to you?
Well, that's a good question. Data activation means that there is a lot of data in healthcare. We have a ton of data. The ability to actually use that data in an appropriate manner that actually assists us with what we're trying to do is really the data activation, the definition of data activation to me. So what you guys do for PSW is allow us to aggregate all of our data and identify ways that we can utilize the data to improve the cost of care and improve the quality outcomes for our patients.
Yeah, I think we often think about the importance of having high quality data and then getting information, not data, to the right people and insights, just like using a smartphone with Waze or Google Maps tells you what to do based on how things change. It just gives you directions and some insights and some choices you can make. So taking that data and activating it sounds very helpful. Sounds like we may have lost Phil, but I want to talk about this concept and spend some time on it before we get to our audience questions. I think, Melanie, you were talking about just sort of this role, and I really love that story you told about the patient with, social isolation. The data and technology aren't going to solve everything. And at fee for service, the application of direct clinical interventions doesn't solve everything either. So I think there's a need for augmented intelligence, given that data and insights can help us from the machines can really help us be better humans, better caretakers, better physicians, better clinicians, better home care agencies. Can you say a little bit about how you see the human touch playing out as you move toward risk and whether helping or hurting that direction?
Yeah, definitely. I mean, I think that you have to adapt a little bit to your audience in terms of what type of provider is really going to get on and log on to a system and do a self-service to figure out how to use a tool. And then you've got the other end of the spectrum where you need to push a report or a conversation, maybe even just a dialogue with providers. So I'll give you an example where we use some of our risk stratifying profiling for the patients that might be at higher risk. Tamra provides us that list, and then we sit down with the physician, one of our medical directors, and said, hey, on this list, who are you really worried about? So we use AI to help guide the prioritization, but then we have some conversation with providers around what they know, sort of the art and not the science behind behind knowing their patients. And then we put like a, simple, but a little just asterisk next to those patients that the physician says they're concerned about. And then we put those patients on the top of our list for outreach, because we're able to utilize some of the AI principles to help us narrow the list, but then we get some of the engagement for the art and the science part of medicine. So I don't know if that answers your question.
No, absolutely. And both myself and Dr. Paul Grundy, who was known as the godfather of the patient-centered medical home, really talked about this concept of the care team, right? It's not about a physician, patient, or a home care worker just seeing a patient in the home. It's really about the team. Or can you say a little bit from a digital health perspective, how you see technology really helping to augment the team itself?
I think that, this is Tamra, sorry. I think that within the system, we have what we call a patient 360. They're given all of the information regarding many different pieces as it relates to the patient, all in one place. And so when a care manager or even the provider is working with the patient, they understand who else is working with the patient, what they're working on with that patient, and they're given all of the information. We're able to see what medications were ordered and did the patient actually fill those medications or not. And if they didn't fill those medications, we have information that we work with as a care manager with the patient on social determinants and determine whether or not there's something that we could do to assist them to get their medication filled. And I'm just making, I'm using a particular instance of something that we're able to do. But I think the technology has allowed us to have all of that information in one place at the time that we're working with the patient. And so we're able to augment that work with that patient and do it in a way that really is much more sufficient or efficient.
That makes a lot of sense. And my experience working across the country with different folks, if you can free up their time through the use of data, allow them to spend more time with the patients, they feel like they're returning to the practice of medicine. It's great. So I was just looking through some of the questions. We've got a ton of questions from the audience here. This one might be best directed to Melanie. One of the audience questions is, why is the uptake of advanced practice models, APMs, amongst provider organizations been so slow to date?
So I would think that, look back to the cartoon that you had around change, right? Just the concept, change can be uncomfortable and requires a shift in strategy and resources and change management and all the things. But I would also say that when you are taking costs out of the healthcare system, that's somebody or some portions of the system's revenue stream for financial, success or to be financially soluble. So one of the things I think is that the concern that you're going to not have sustainable margins is a big and real concern around, or a deterrent to engaging in the models right away. I think it's also all kind of an experiment right now. I mean, I think we're moving from the experiment to the adoption phase more broadly over the next 1 to 3 years, and the policy implications would suggest such. But a lot of this has been a test, and I think there's skepticism around, is this, you know, the new shiny object as a healthcare thing, and will this be a fad, you know, just a passing fad, or will this really materialize as the new system in healthcare? So I think sort of letting other people go for it first, and then also lastly, and probably maybe more significantly even, is that it takes financial reserves and a real risk in terms of financially funding escrow payments and required you know, cash down to participate in the up and down models. So you've got to have the ability to fund those models. You got to be able to proactively fund the infrastructure and technology and all the things to be successful. I mean, that's a big commitment to be made. And so I think that that's one of the drivers. And some cases in the country, certain areas have different payer landscapes where some are interested in sharing risk, some are not. And so it depends, I think, as well in where you are geographically. So I don't know if that answered your question.
No, I'm asking the questions to the audience, and I think it certainly does. You know, another related question, which you just started to get at, which is, what are, from your experiences, and I'll open this up for Tamra or yourself, what are the provider traits or practice traits that really predict success in value-based care arrangements?
You go ahead, Tamra.
Oh, okay. I would have to say that my experience has been that the independent provider has good outcomes and is willing to engage the patients in a different way. But they also are the ones that have the least ability to stand something up like this. And Melanie, I'm gonna move this one onto your plate to complete the answer.
Well, I think if we're talking about the transition for an independent provider, one of the things I feel is very interesting in the data, and the Medicare CMS press releases related to ACO performance would suggest that physician-governed and independent physician-governed practices show better cost of care compared to other like vertically integrated systems. But I think to what Tamra was alluding to was that there's less, not, you know, discretionary profits or earnings or reserves to make those investments. So I think that's one of the reasons that we've tried to assemble and expand our organization to other independent physician groups, is that there's a real compelling case that everyone can participate in APMs, and independents, even if they're small, you know, independent practices, can be very beneficial and could be successful in establishing the goals of improving quality and reducing costs. So we feel very committed to that as sort of a mission, if you will.
That makes sense. And then I've got so many questions here to pick from, but one last question in the minute we have left is, what technologies and what companies are you using or do you see as helpful as providers move into this sort of risk-based arrangement that you've had this great experience with?
Well, I'm going to tell you my thoughts in 30 seconds and let Tamra, but we learn a lot about how to be successful, about what not to do, right? And then that's important to share those learnings as well as folks are moving into the risk-based business. One of the things that we found, and Tamra can speak to the differences in terms of the technology platform, but one of the reasons that we had selected to use Innovaccer as our platform was that it was a very engaged and adaptable learning model where we were collaborating with the team there around what was the best use of actionable data and how to really stand up the platform quickly and efficiently and cost effective. And so we did an extensive RFP as we looked at scaling our organization and using a tool to help us find the needle in the haystack. And so we did an exhaustive search really of the platforms available to come up with one that was going to work for our unique situation. So Tamra, comments?
No, I think you covered that. I think that I think it's important to note when you ask what technology are we using, we really did try to find a platform that allowed us to not have to do integrations with multiple different other platforms. So what we found in Innovaccer was the ability to do our care management at the same time as our analytics and do our point of care and social determinants of health and closed loop referrals. So it's very all encompassing as a platform. And yes, we are using a aggregated ADT feed that we integrated in with the platform. But when it comes to other technologies, I don't believe that we have a whole lot that we've added to those two systems.
Well, I appreciate the comments and certainly appreciate having worked with you. And more importantly, I really appreciate your working with us on this webinar. So a big round of applause to Melanie, to Tamra, to Phil, all for joining us. I think with this concludes the webinar. Thank you very much to our panelists. Thank you very much for our audience for coming. And you'll be receiving the State of the Union report from Innovaccer, and looking forward to our next engagement and our next webinar. Thank you all. Thanks for coming and thanks for participating, Tamara, Melanie. Appreciate it.
Thank you.
Thanks, Dr. Nace. Bye.
All right. Bye-bye.